I would like to talk about the Ozurdex, especially in its role in retinal venous occlusive diseases and non-infectious uveitis. I think it is important to talk about the Ozurdex a little bit more, to know a little bit more about the steroid implants, because yesterday in the debate I could see that the audience had some kind of reservation against the steroids. However, I think this is a very important tool in our armamentarium. So the venous occlusive diseases, as we know, are potentially vision-threatening conditions. Different pathologies and complications might develop during its progression, but the main cause of the visual decrease is macular edema, which is responsible for the final visual acuity not more than 0.4 in 80% of the central retinal vein occlusion, and even in branch vein occlusion cases, the vision is not better than 0.5 in 66% after 3 years. So our goal of treatment is to save the vision and to treat the macular edema, and first of all, to prevent the chronicity. The macular edema is a principal sign of inflammation in the retina, this is a multifactorial disorder. Multiple cytokines and chemokines are contributing to its development, but the two main contributors are considered still the VEGF and the interleukin-6. If we have a closer look at the level of these agents inside the eye, we can see that the VEGF level is still normal in 30% of the cases if we compare to the control group, both in branch and central retinal vein occlusion. However, the interleukin-6, it is always higher in these diseases if we compare to the control group. So maybe the interleukin-6 is a better discriminator for the disease than VEGF. So definitely we might think that we could have a better result if we control all the contributing factors, block all the inflammatory pathways, both the VEGF-dependent and VEGF-independent factors, and those drugs are the steroids. So steroids might block, inhibit, stimulate, and decrease different factors. They increase the tight junction integrity. They are able to control the leukostasis, which is considered the critical element in the inflammation. They are also able to enter to cells to block the intracellular inflammatory signals. So regarding and considering all these facts, the Ozurdex was developed, which is a 0.7 milligram dexamethasone pellet, 6.5 millimeter by 0.45 millimeter in size. It is biodegradable, and it can be injected into the vitreous cavity through a 23-gauge needle with a single-use preloaded applicator. It releases dexamethasone for 4 to 6 months, and it is not only FDA approved for treatment of non-infectious uveitis, retinal venous occlusive diseases, and diabetic macular edema, but it is approved for all these 3 diseases in UAE. The first study about the Ozurdex was the Geneva study, which was the biggest ever study about retinal venous occlusive diseases. Sorry, but this device is a little bit difficult. So the study design was that patient received the Ozurdex implant at day 0, and the primary endpoint was at 6 months, when all the patients were retreated with the 0.7 milligram dexamethasone implant, unless the vision improves to 20/20 or central retinal thickness reached 250. The final visit was 6 months after the second injection. I have to mention about the patient selection that in this study, patients were accepted, not only the fresh cases, but the patient who had a persistent macular edema for 3 months. So all these patients were included in the study. And I will explain you why I am emphasizing this. Can you tell me where should I turn this pointer? Because sometimes it is goes, sometimes it is stuck over there. Yeah, maybe like this. So there was a significant visual improvement in the dexamethasone group compared to the control group. However, there was a fluctuation in the vision by the end of the 6 months, but the vision was regained when re-injection happened. This might be contributed to the patient selection. Up to 29%, the patient achieved 15 or more letter visual improvement. The adverse effects were quite favorable. The major adverse effect was the subconjunctival hemorrhage. The cataract formation did not reach 12%, and the ocular hypertension was a little bit above 3%. After the Geneva study, several retrospective study was done in Germany, in Italy, and in France. The biggest study was done in France, which involved 220 patients. The study design was quite similar to the Geneva study, but in this study, the fresh cases were involved, and not a long-standing or a longer-standing, not a longer-standing macular edema. And the patient received the second injection as needed. And this can be the responsible for the much better result of the visual acuity, because if you have a look at the results by 3 months, almost 50% of the cases regained, almost 50% of branch and central retinal vein occlusion cases regained 15 or more letter improvement, and it was maintained in 31 and 38% by the end of the 6 months, opposite to the Geneva study, which was only 22%, which also shows us how important to treat the patients early. And this is the results with one single injection, and these results are quite comparable with the Bravo and Cruz study, but with only one injection. The adverse effects were actually lower than those reported in Geneva, and the IOP elevation was transient and manageable. 49% of the patients had the second injections, and 30% of those patients had the second injection at month 6, and the rest of the patients received earlier. The mean time of the injections was 5.3 months, and the follow-up at month 4 was particularly important because the recurrence happened around that time. So the conclusion was that the Ozurdex is an effective treatment tool with a well-tolerated safety profile, but we might need to inject the patient earlier than 6 months if they need re-injections. So we can conclude that the short duration of the disease is very important for the favorable visual outcome, and approximately 50% of the patient needs only a single injection with a well-tolerated profile. If we give multiple injections, we might select the patient a bit more carefully. The ideal patient is a pseudophakic who is non-glaucomatous, non-steroid responder, usually the elderly patient. And this can be the best option in case of the suspicion of difficult follow-up in elderly patient with existing cataract in vitrectomized eyes, because it is proven in the studies that there is no difference between vitrectomized and non-vitrectomized eyes. You can use it in contraindication for anti-VEGF and even in refractory cases, but of course, for other drugs, but of course you can expect a little bit worse visual result. The next indication is the non-infectious uveitis. We all know that the key component is the inflammation. The systemic drugs are, of course, effective, but with serious adverse effect, so it looks a logical solution, the intravitreal therapy by Ozurdex, to decrease or eliminate the side effects of the systemic drugs. The Huron study was conducted to evaluate the efficacy and the safety in the treatment of non-infectious intermediate and posterior uveitis. The study design looked like that. There were 3 groups, one sham group, one group with 0.35 dexamethasone implant, and another group 0.7 dexamethasone implant. The efficacy was measured by the vitreous Hayes score, and it was measured by the standardized photographic scale. The patient received the Ozurdex at day 0. The primary endpoint was at 8 weeks, and the final visit was at 26 weeks. We can see that the proportion of the patient achieving vitreous Hayes score 0 was significantly higher in the dexamethasone group. It was approximately 4 times higher by week 8. The vitreous started to clear up from around the 3rd week, and it lasted up to 2 months. There was a significant visual improvement in the dexamethasone group, and this visual improvement was practically maintained during the whole study period. Up to 43% of the cases achieved at least 15-letter improvement. So the take-home message can be that the Ozurdex is quite an effective treatment alternative for macular edema in the central retinal vein occlusion and central branch retinal vein occlusion and in the non-infectious uveitis. It has a very established safety profile. However, we have to keep the eye on the IOP elevation and the cataract, but mostly if we use multiple injections. And I want to emphasize this because what I think that still in many of our minds when we say intravitreal steroids, immediately the intravitreal triamcinolone will come in our mind, which years ago was administered with very great enthusiasm, but the results were not as good as it was expected, and that's why it was abandoned. But I want to remind you that Ozurdex is different. This is a much more sophisticated steroid, and there are very stable studies about the safety profile. And this is one tool in our armamentarium. We should never put patients, let it be a central retinal vein occlusion, branch vein occlusion, or diabetic macular edema. You should never put everybody in the same basket. You have to examine the patient, you have to select the patient, because each patient has its own characteristic, and each patient has the best medication, the best drug for the treatment. So the patient selection is exceptionally important in this case as well. So thank you for your attention.
Thank you.